Hello, everyone, and welcome to Grand Rounds event today. Whether you are joining us in the Rangos Auditorium or somewhere else virtually, we thank you for your time to attend this special presentation. As a reminder, for those who are virtual, there is not a separate link for the meet and greet today. The meet and greet will be integrated into the lecture at the end. If you would like to ask a speaker a question, please type it into the Q&A. If you would like to engage with the presenter, we ask that you raise your hand and we'll bring the mic to you. If you would like to engage, we'll ask the webinar host to unmute you and you can turn on your camera. If you are attending in person and would like to engage, just raise your hand and we'll bring the mic again to you. We have also posted the QR code for today's Mock 2 quiz in the back desk for those who are attending in person. We are honored to have Dr. Carla Mazefsky speak with us today on emotional dysregulation in autistic individuals today. Dr. Mazefsky earned her PhD in clinical psychology from Virginia Commonwealth University. Having completed her clinical internship at Brown University School of Medicine. She remained at Virginia Commonwealth University for postdoctoral training at the Virginia Institute of Psychiatric and Behavioral Genetics. She joined the University of Pittsburgh as assistant professor in pediatrics in 2006, and then shifted to the Department of Psychiatry in 2009. Dr. Mazefsky conducts research on autism spectrum disorder, investigating mechanisms, correlates, assessment, and treatment of emotional dysregulation in autism across the lifespan. Dr. Mazefsky is one of the creators of the Emotional Dysregulation Inventory, which is currently used nationally and internationally in both autistic and non-autistic populations. She is co-author of the Emotional Awareness and Skill Enhancement Program in Emotional Regulation Treatment for Autistic Teens and Adults. She has consistently obtained federal and foundation funding to sustain her program of research. She is currently PI of 2 NICHD R01s, a DoD-funded randomized controlled clinical trial, and most recently, a very, very prestigious NIMH P50 Autism Center of Excellence Award, which is amazing, as well as collaborative efforts. She is not only internationally recognized leader with regard to research achievements, but she is a local leadership role regarding research mentorship and integration of clinical services, clinical research, and clinical basic science with autism within the psychiatry department and university more broadly. Please join us in welcoming Dr. Mazefsky.
Thank you. And I'm very sorry that I cannot be there in person. 'Tis the season for illnesses. So hopefully this goes smoothly. Okay. Oops. It's not, oh, there we go. Okay, first, just my disclosures, grant funding, and this book. Okay, so today I really probably prepared too many slides, but I thought I would attempt to address the importance of emotion dysregulation in autism and how it can alter the course of autism spectrum disorder, introduce you to the emotion dysregulation inventory, and then also provide some practical tips for working with autistic patients. I'm going to use identity first autistic language based on preferences expressed by many autistic adults. And then my other goal is, I don't know how many of you are familiar with our research program, so I'm hoping to kind of highlight the many different things that we have going on that you might not be aware of just down the street in Webster Hall in Oakland. So we call ourselves the REACT program. We primarily focus on emotion regulation, mental health, and behavior in autism spectrum disorder. A lot of our focus is on measured development and applied research focused on supporting well-being in autistic individuals. My particular emphasis is adolescence and adulthood, but we have studies spanning ages 3 through late life. We also have a growing number of faculty, collaborators, postdocs. We have Kate Keelty, our first pediatric fellow, and many trainees. And we also work very closely with a group of autistic adult advisors and mental health clinicians in the community and advocacy leaders, our PARC group. And I just want to mention, I'm very passionate about growing our autism research within the university and bringing people together. We've recently started a quarterly Pitt Autism Researchers meeting, and if anyone is interested in joining those initiatives, please reach out to me. Okay, so I imagine most people are at least somewhat familiar with autism spectrum disorder. The definition is based on social communication and social interaction deficits, as well as the presence of restricted and repetitive interests and behaviors. But what I'm actually most fascinated by with regard to autism is the tremendous variability that you see in terms of intellectual ability, language, co-occurring psychiatric and other conditions, and the degree of support needed. And I'm particularly focused on the wide range of mental health problems that come along with autism spectrum disorder. This is just a summary slide. Basically, the bottom line is almost every single disorder is much more prevalent in autism as compared to outside of autism, although the ranges are variable. I don't focus too much on very disorder-specific approaches because it's really challenging to diagnose psychiatric conditions within autism because the boundaries are difficult. And what you find if you do a structured psychiatric interview is that most meet criteria for multiple disorders. So it becomes a little bit less efficient to look at it that way. And instead, we focus on the underlying process of emotion regulation or dysregulation, as well as other transdiagnostic processes such as aggression, self-injurious behavior, and suicidality. So I thought I would take a step back and try and convince you that this should be a topic of interest to you. First, there are very high rates of medical comorbidities in autism. So especially things like epilepsy, GI conditions, many, many more. So even if you don't specialize in autism, it's quite likely or almost guaranteed that you will work with autistic patients at some point in your career. Also, recent research really suggests high premature mortality, that research is just beginning, but some of that is linked to medical conditions as well as suicidality. And then the other key point is that often we see emotion dysregulation during medical procedures and appointments. And then there's also a reciprocal relationship between medical conditions and emotion dysregulation, where sometimes the emotion dysregulation actually stems from pain or untreated or unidentified medical conditions. What particularly motivates me can be summed up in this quote that I received in a random email from a parent who I don't know, but she reached out to me and I think says it quite eloquently. So this is from the mother of a 9-year-old son with autism. My husband and I describe him as being at once the most capable and most disabled person we know. His dysregulation manifests in severe emotional outbursts, both verbal and physical. However, when regulated, he is more rational, kind, and mature than his older neurotypical brothers. Emotion dysregulation is absolutely his chief obstacle to living a full life and having the chance to enjoy his many talents, and they are many. So this is really the entire goal of our research program, is to support well-being, quality of life, and reduce the interference of emotion dysregulation. So when I got into this, one major barrier is that there were not appropriate measures to study emotion dysregulation in autism. Usually autistic individuals were excluded from measure development initiatives, and most measures were not appropriate for those who were speaking through non-speaking. So we spent many years and a lot of systematic effort developing the emotion dysregulation inventory using NIH PROMIS methods in collaboration with Paul Plakonis and Lan Yu. I'm just going to highlight a couple of key things that I think help that process be successful. The first is that and I should say it's a questionnaire. So when we developed our draft items, we then did interviews with parents, asking them to describe in their own words what it means, to talk out loud as they were answering the items, give us any suggestions. And I think this really helped us make sure that it was capturing the pertinent constructs and being understood in the way that we intended. And then next, we validated it and did our psychometric analyses in very large representative samples. So we used the IAN Interactive Autism Network, which is a national autism registry, so representative of those with professional ASD diagnoses. Importantly, I've been part of the Autism Inpatient Collection study for 8 years, which is focused on psychiatric inpatients with autism, and we included 432 AIC participants so that we could ensure we were capturing and able to tap that more severe range of emotion dysregulation. And then we also used a US Census matched large sample. So I'm going to avoid a statistics lesson, but we used IRT, which item response theory analyses, which basically is much more precise than classical test theory. So instead of basically each response having equal weight across all items, having, like, for example, very severe on explosive outbursts can be weighted more strongly than very severe on gets frustrated easily. So it allows you to develop a more precise measure and to also look at the individual item level characteristics when we're choosing our items. And the other thing that was helpful about IRT is it allows you to look for differential item functioning. So we were able to test and make sure that there were no biases based on language ability or intellectual ability, so that it could be used across the full spectrum. So it's now a rare tool that can be used across any verbal and intellectual ability. It's sensitive to change. It has norms and clinical cutoffs. It's efficient and precise. We have a 6-item and 7-item versions. And then importantly, it's validated in autistic and non-autistic populations. So it can be used in general clinics. It can be used across populations. This is just an example of what some of the items look like. So it has a reactivity scale and a dysphoria scale. Reactivity is tapping things like intense, rapidly escalating negative emotion that's difficult to downregulate. Dysphoria is a bit more of like difficulty upregulating positive emotion and general unease. And it's free to use. And it's also an Epic, but I don't know if you use Epic. Okay. So our original version was for ages 6 and up, and then we also recently finished development of a young child version that's for 2 to 5-year-olds that's linked psychometrically to the older version, which allows you to follow people over time. We wound up with the exact same type of scales for reactivity and dysphoria, and I just want to point out that Pediatric PitNet was a partner, and all 10 CPP practices supported enrollment in this study. Okay, and then we are also in the process of developing a self-report version. We are collecting data now to do psychometric analyses, and that'll be for ages 11 through adults. And I'm not going to go into these other ones, but just a couple of other ongoing projects are the EXPAND study is a measure of autism symptoms for 3 to 11-year-olds. The REAL study is focused on employment, relationships, autonomy, and satisfaction measurement for adults. And then I'm a mentor for Hilary Schultz at UCLA, who's developing a loneliness measure. Okay, so hopefully we put all that to good use. I mean, I think we've learned a lot. One of the big lessons we learned is, we always thought that emotion dysregulation was more common in autistic youth, but we were able to now document it using very large samples. Reactivity is autistic children are more than 4 times likely to exceed clinical cutoffs. Oops, what happened there? For reactivity, and over twice as likely to exceed clinical cutoffs for dysphoria as compared to the general population. However, what's interesting is that even within autism, emotion dysregulation is highly variable. So if you look at this far right census match group, that's the general population, and you'll see this is basically showing that most of the population has low levels of reactivity and very little change over time. In the middle, that's a community ASD sample from Ian, where you see huge amounts of variability in terms of severity and change over time. And what's also interesting is, even in the inpatient ASD sample, where you would expect it to be high, you still see a pretty dramatic amount of variability, although it's right shifted to be more severe. And that variability is important because when emotion dysregulation is high, it can have very negative outcomes. Using cross-sectional methods, we've shown that emotion dysregulation on the EDI is related to higher depression, anxiety, and aggression symptoms, more suicidal thoughts and behaviors, and importantly, real clinical outcomes such as the likelihood of being on psychiatric medications or multiple medications, having had a crisis intervention such as police contact, ER visits, in-home evaluations, and the likelihood of hospitalization. We've also looked at how emotion dysregulation relates to other behaviors in real time. So behaviors such as self-injurious behavior and aggression. So this was a study that took place on Western Psych Hospital's autism inpatient unit. And our amazing research assistants here and at 2 other sites spent 506 hours of time on the unit observing patients and rating the onset and offset of aggression, self-injury, and emotion dysregulation. And this allowed us to look at how often emotion dysregulation occurs with or without overt, so observable emotion dysregulation. And so what you can see here is about half the time self-injurious behavior occurs with emotion dysregulation, and less than that for aggression, about 36% of the time. And this is just pointing out here on the bottom, these are frequency plots, again, how variable that is. One of the things we've really wondered is, that's overt emotion dysregulation, and are we missing something? Because we know that sometimes the way in which autistic individuals show their emotions is different. So we also collected data using sensors for physiological arousal and applied machine learning analyses to see if we could predict the onset of aggression based on preceding physio. And we were able to do so with high accuracy 3 minutes prior, suggesting that there's something going on with their arousal and distress. So we're building on that work right now with Matt Siegel at Maine Medical Center and collaborators in the Department of Psychiatry, including Lauren Balsma, Helmut Karim, and my postdoc Safa LD. And we've now collected physio plus the observational ratings of aggression, self-injurious behavior, and emotion dysregulation in 95 inpatients. And we're going to be applying machine learning to that and hope that this can eventually be used to develop devices that would alert one to the risk that something is imminent, or that de-escalation strategies might be needed, and even for self-awareness of emotion dysregulation. Other questions we're asking are, we know that reactivity doesn't always go together with aggression, and some may have high reactivity and high depression, but not high anxiety, or different patterns of behavior. So we wondered if there are, important clusters of individuals based on their psychiatric symptom and behavioral and emotion dysregulation profiles. Again, using machine learning techniques, we're planning to cluster, or we are clustering data from over 1,000 inpatients with ASD and 1,300 community sample, where we're taking data somewhat like this, where we're just throwing all the items in and hoping to find what are unique, distinct clusters. I think I'm going to skip like the specific results of this now, but we do have results, and we got 4 different groups that differ based on patterns of reactivity, dysphoria, anxiety, withdrawn depressive behavior, SIB, and aggression. And I was also happy to see it wasn't just like all inpatients in one group. The groups are a mixture of inpatients and community sample with ASD. So our next step is we're going to be looking at what predicts cluster membership. Is it something about their communication ability, their intellectual ability, and other data that we have? We're also interested in looking at self-injurious behaviors, which can show up in many different forms, and whether or not we can identify clusters of people who have similar types of self-injury, and then hopefully use that to understand factors that contribute to risk for different types of self-injury. This is being led by my postdoc Lehia Antizana and Helmut Karim. The other outcome that we're really interested in is suicide. More and more research is suggesting that autistic individuals that are at much higher risk for suicidal ideation and death by suicide. I'm just going to give a couple of statistics, although this literature is really in its infancy, I would say. Online studies show about 20% have endorsed thoughts. If you look at clinical cutoffs, more than double autistic individuals exceed clinical cutoffs for suicidal behaviors. In clinic-based samples, you see very high rates of endorsing having had a suicide plan or attempt. And then you also see this confirmed in state and county death records. The rates are much higher among autistic individuals. However, this research, like I said, is somewhat a new field, and it's really lacking in several ways. It's cursory, mostly samples of convenience or correlations with self-report questionnaires. There's not been one single study of neurobiological or physiological mechanisms related to suicidality in autism. And then almost all of the research has looked at suicidality by itself without thinking about the other impairing manifestations of emotion dysregulation or non-suicidal self-injury or aspects of resilience and protective factors. So this is something I'm very excited that we're going to be addressing in our new Autism Center of Excellence grant, which is focused on generating measures and mechanistic targets to improve mental health and suicidality for autistic adults. This is an adult-focused study, but hopefully if we can start to learn about adults, we'll know that'll also give us insight into childhood. And we've also really found that we benefit from working very closely with our autistic adult partners to understand their experiences as children. Anyway, I know that you're focused on pediatrics, but I wanted to mention this. So these are really exciting grants to have. There's 9 of them in the country, only 6 of them are centers. In ours, we're going to be recruiting 200 autistic and 100 non-autistic adults. And what I think is unique is that our non-autistic adult sample is not like a squeaky clean sample. They're also going to be at least half currently suicidal. And the other thing that's really exciting about this ACE initiative is how it's bringing more people into autism research and bringing together a lot of different perspectives. Over 20% of our team is autistic themselves. We have assistant professors, 2 endowed chairs. We have people who focus only on autism research, those who've been our collaborators for a while, and then we have many who are brand new to autism, which is really exciting. And then we have a lot of external partners and consultants in the community and from other universities. At the bottom are the leads, Lauren Bilesma, Annie Cohen, Caitlin Connor, Ben Handon, Lori Scott, Greg Siegel, and Kelly Beck, who are all in the psychiatry department. So in brief, this is going to consist of 3 projects and 3 cores. The first project is focused on developing a self-report measure of suicidality that's dimensional. So we're hoping that it can capture a continuum of risk and help us develop prevention and treatment efforts. The second study is going to be focusing on daily life, where they'll be wearing physio monitors and responding to cell phone prompts using what's called EMA for questions. And sometimes those questions will be triggered randomly, and other times they'll be triggered by changes in their physiological reactivity. And then our third study is focused on neural reactivity to many different affective, sensory, and social stimuli. So It's very exciting because it's going to give us some measures that we can actually use in future research, hopefully identify some mechanistic targets for treatments, including just-in-time interventions and personalized interventions, as well as point us towards biological and psychosocial factors that confer the highest risk for poor outcomes to support future personalized care and prevention. This is just illustrative of one of the things that we can do with this. We're going to be collecting huge amounts. Well, I should say everyone's going through all 3 projects. So we're going to be collecting huge amounts of data on everyone. And there's a very unique opportunity to pull together all these different levels of data about their reactions at different timescales, their history with trauma, gender identity. We have such a large battery of many different things. We're even going to be able to calculate brain age, looking at if their brain age is either less mature than would be expected based on chronological age, or if there might be accelerated aging, which is important because we know like virtually nothing about this in adulthood. So we can pull all of this together to get what most strongly predicts suicidality or positive outcomes, such as flourishing a year later, and many more things. This is just one example. The other thing that I want to mention that's likely relevant to this group is that it has these cores, one of which is the dissemination and partnership core, which is really focused on doing a better job disseminating our research findings to clinicians and to the lay community. And it will include a continuing education seminar series for community providers. We're identifying the topics in partnership with our PARC group that I mentioned earlier. The first one is going to be on how to make inclusive environments, which would probably be pretty relevant to this group. We're also going to have a lot of career development opportunities and initiatives to support diversity in autism research. So all of that is kind of exciting stuff on the horizon, but so you have a patient that comes in your office now who's upset or dysregulated, and what can we do to help? So I'm going to summarize just some basics of what's out there, as well as pull from some of our treatment development research. One of the things that I think is really important is that emotion dysregulation can really bend the developmental trajectory. It can limit opportunities to participate in school. It can limit response to treatment. It can lead to worse family functioning. And I really think it's important that we start to think about how we can catch it before things are really terrible. And that could be done with screening. So that's one of the reasons I'm very excited that we now have the EDI with clinical cutoffs. So we keep track of everyone who's requested the EDI, and I actually thought that maybe it wasn't used as much in pediatrics. I just assumed it was more commonly used in mental health, but I was pleasantly surprised to find all of these pediatric departments are using the EDI. Some of them are using for screening in their clinics, and others are in a research context or in treatment context. Also being used all over the world in many different disciplines in all these locations. However, it is not yet being used in our own pediatrics department or Children's Hospital of Pittsburgh. So throwing that out there, it's free. And I just noticed as I was going through this one really interesting example at Harvard, Boston Children's, where they're studying interventions to improve emotion regulation in the context of orthopedic surgery for autistic individuals. I thought that was kind of interesting. Another key point I would say is that I think it's our duty as providers to not pass along misinformation. And this quote is a quote that I received from a parent, again, someone I don't know, but just reached out to me. And it is illustrative of countless similar emails I get. So I'm just going to take a moment to read this. My 27-year-old daughter suffers acutely from emotion dysregulation, manifesting through meltdowns, self-injurious behavior, and suicidality that no one seems to know how to treat. My daughter has been hospitalized many times and medicated heavily, but the psychiatric community does not appear to have familiarity with the kinds of therapeutic techniques that are being used successfully with ASD patients. we've looked extensively, but both the hospital-based and community-based DBT, dialectical behavior therapy, and cognitive behavior therapy programs have uniformly told us either that they don't accept patients with an ASD diagnosis, or that CBT and DBT cannot be used with autistic patients, which is just completely not true. And I've heard this a million times. So I think we want to make sure we're not sending that message, even if clinicians do not feel comfortable. And importantly, there's a lot of growing research on how to adapt traditional interventions to be successful with autistic patients. This is just one example of a paper that we wrote on this topic. But the bottom line is traditional psychiatric interventions can be successfully used with autistic patients. In our work, we've done a lot of mindfulness-based interventions, and led by Kelly Beck, we've really come to better understand ways in which mindfulness can be modified successfully with autistic individuals, including those who are non-speaking. There are also emerging treatments that were developed specifically for ASD. These are some examples of them here. I would call this research quite preliminary, though only 2 in yellow are I want to call attention to because they have had randomized clinical trials. Regulating Together is led by Rebecca Schaefer at Cincinnati Children's, and this one is noteworthy because the Center for Autism and Developmental Disorders at Western Psych is getting training in this program later this month, and we'll be opening a new emotion regulation focused intensive outpatient treatment program for emotionally dysregulated autistic kids, which is very exciting. I plan to keep them very full with referrals. And it was Regulating Together is designed to be an intensive outpatient program that's shorter in duration, but intense, twice a week, longer sessions. EASE is the program that we developed. We have a published open trial, and we'll be having our last participant finished this month for our randomized control trial, which is very exciting, and have the possibility of an upcoming comparative effectiveness trial with 10 community clinics. So I'm going to just, rather than telling you too much about EASE, I'm going to sort of integrate in some of the key things we've learned in the experience of running the trial. But I did want to note that it's a collaborative effort with Susan White at University of Alabama, formerly at Virginia Tech, and Caitlin Connor and Kelly Beck here in the psychiatry department. It is a 16-week individual therapy program targeting emotion regulation. It's primarily mindfulness-based, although we do focus some on thoughts and a few CBT type techniques. We really designed it specifically for adolescents and emerging adults with autism or autistic. And we did that in partnership in the development process. We had feedback from an autistic psychiatrist, parents of autistic individuals, and we really refined it with more feedback after our open trial. So it's really been refined over time to be optimized for use in autism. And parents are involved, and that's to different degrees based on the child's needs. But basically, the idea is it includes a very intense focus on increasing awareness of one's own awareness of their emotional reactivity. It is more of a distress tolerance and non-judgmental model, kind of in line with mindfulness. So the idea that not all emotions are normal. It's very appropriate to be angry or upset in certain situations, and the goal is more to stay calm in the face of strong negative emotions. Mindfulness is also used for physiological calming. We teach specific distress tolerance strategies, and then we do a lot to support generalization into the community and outside of the clinic. We embed in specific sessions where we try and more so mimic real life situations, bringing in a sibling, going out literally into the community, and having more real world practice. The goal is to improve emotion regulation with downstream improvements in depression, anxiety, and reduction of aggression and other behaviors. One thing I'm really proud of is that we started this in 12 to 17-year-olds originally with with average intellectual ability who are speaking, so more like your traditional therapy client. But of course, those who are non-speaking often have much more limited options, usually just focusing on medication, often with heavy side effects. So we undertook this effort to see if we could modify ease to be used with those who have intellectual disability and may not be fully verbal. And it was a huge success despite happening in the middle of a pandemic. And this is just some example of how we're now working to blend the two interventions. So it can be one manual that can be used by clinicians to work with a variety of patients and understand how they might pull in different things based on the client's needs with verbal ability, intellectual ability, and so forth. Hopefully, this will make it easier to disseminate if clinicians can have like one kind of go-to manual. The other thing that we have done a lot is work directly with stakeholders to understand their perspectives on mental health service needs. This was led by Kelly Beck and her KL2. We also work closely with our PARC group. So Kelly ran qualitative interviews with autistic adults, autistic adolescents, caregivers, providers, mental health providers, to understand what their experiences have been with emotion dysregulation in the community and their needs for mental health treatment, and with the goal of helping us to understand how we can better work towards implementation of ease in the community. So one theme that came up that I wanted to highlight is one of the questions asked was, can you tell me a story about a recent time you were out of control with strong negative emotions? And nearly every participant shared a story of a meltdown that occurred on the way to or in a healthcare setting, just again reiterating the importance of this topic. Our autistic partners have regularly highlighted these key points. Often they find that healthcare interactions can be inherently disruptive and stressful. They're often not sensory friendly, or getting access and scheduling appointments can be a challenge. Often feeling kind of unheard or not listened to. I've heard a lot about feeling invalidated in their concerns, or not feeling safe and supported. So important things to keep in mind. And then I think there are some easy mistakes when we mean well, but might actually serve to escalate a situation if you're working with a distressed autistic individual. So I wanted to highlight those. One thing I've heard time and time again is telling them to calm down, relax, or just breathe. And I was laughing because it's happened just this morning with my typically developing 14-year-old daughter who was crying over something. And my husband said, stop crying. And that never works, even if you're typically developing. Like if you could just pull it together that instantly, you would. So really important to not do that. The other thing that can increase stress is demanding eye contact when they're upset. The other things are probing specific questions about how are they feeling? Why are they feeling that way? And that's counterproductive because those are skills that are very hard for most autistic individuals. So it can just increase their stress. And then the other key point is we've heard a lot from autistic individuals about how engaging in stereotyped and repetitive behaviors is actually calming for them. So even if it is part of a treatment plan to reduce those things, it's not the time when if they're rocking, when they're distressed, or they're doing something repetitive, to definitely let that go, as it's a coping mechanism in most cases. Some other tips are having social stories for all procedures. There's an example of one below. Talking in short sentences with processing breaks, being patient, allowing them to respond, checking if they understood what you were saying, giving concrete choices with images, and I would say not too many choices, and then engaging in their interests to show support and increase rapport. The other thing that can be very helpful is to plan ahead and use available resources. And I'm going to talk about some of those resources in a minute. This is just an example of a questionnaire that could be sent prior to an appointment about their experience with medical procedures and their parents' typical strategies for handling this, which I think could be really helpful as part of a standard procedure to include. The other thing that's really important, and this is something we heavily focus on in EASE, this is an example from EASE, is identifying the distress early. It's much more difficult to help calm down when someone is already extremely escalated. And this is something that can be quite a challenge for autistic individuals. So we focus on this in a dimensional way, just the idea of trying to understand increasing intensity of emotion versus like worrying about if they're mad versus nervous versus scared versus angry. So it can be helpful to understand if they have a language for communicating about emotion, and make sure you're using that in your appointments. Also, I think it's important to stress that it can be when you don't pick up on those early cues, it's kind of a missed opportunity. I just want to provide this one example. Say a child is getting agitated or upset. They communicate that emotion clearly. Either they tell you or they're giving you gestures or eye contact about that. That gives you a chance to provide comfort, help, redirect. And they also, in the meantime, can accomplish what they needed to accomplish, and they're learning to self-regulate. However, often in autism, the communication is ambiguous. They might not be able to identify what they're feeling. They might not communicate that in their facial expressions or non-verbally in the same way. That leads to the impression that a child is going from 0 to 100 instantly because those early signals are missed. And then it can be very hard to calm down or accomplish a task. So this is a really exciting project that my K-23 mentee, Jessie Northrup, who's an assistant professor in psychiatry, is focusing on, where she's working with parents and 3 to 5-year-old autistic individuals, children, and those children, where she's going to be collecting physiological data and questionnaires in a variety of tasks, also in their home environment, to understand differences in emotion communication and how that relates to physio, with a possibility that, again, that maybe we can use physio tools to better understand what we might be missing, so we're not missing those opportunities for earlier intervention. There are some common early signs of agitation that are shown here: whining, rocking, increased repetitive behavior, clenching fists and body, pacing, saying no, increased escape or avoidance behaviors. And the last two, I think, are really important to point out because they might not be as obvious, but often when people are beginning to get dysregulated, it might show up as increased silliness or hyperactivity, roving behaviors. And what we hear a ton from our autistic adults, and is a big component of our ACE Center, is this concept of sometimes just completely shutting down externally while screaming inside. It's called, like, in some people call it autistic inertia, emotional masking, where they might be like trying to hold it together externally. And so it's really important to not ignore a sort of shutdown, not answering, difficult to obtain attention response. If you do notice distress, I'm just checking the time, maintain a warm, neutral acceptance. We use brief, encouraging phrases in EASE, like all emotions are okay. Use their name when talking, and it's okay to label their emotion for them too. Like, say, I can see you're upset. That's different from saying, how do you feel? Reducing environmental triggers, or reducing triggers such as environmental stimuli, like over sensory input that might be unpleasant to the individual, or non-essential demands. And then helping them refocus attention. It's helpful if you have fidget or sensory items available. We use a sensory form of distraction in EASE, where you're creating a sensation, as sort of a temporary distraction before, to give you a chance to calm down before things get worse. And then the other, I think, really critical point is sometimes if there is an incident like a meltdown or aggression, it's often not, even when the actual incident seems done, it's important to proceed slowly. The individual is likely still aroused and processing. And then I have one example. This is from a young man who was in our clinical trial. And this is sort of a real life example of applying those skills to managing distress in real life, in this case, in blood draws, which is often very stressful for autistic individuals. And now this individual is on a lot of medications because his reactivity is over 2 standard deviations above the mean, somewhat lower functioning in terms of expressive language and receptive language at roughly 7-year-old level, despite being 18 years old. Now, this particular individual I know has they've only gone to children's because it's the only place they feel like they can get blood draws. And in the past, what they had to do was have multiple people present to hold him physically still to be able to do it, because it was really traumatic for him and he became extremely dysregulated. So this is just a story, a bit of a session after they talked about trying to use the E strategies for the blood draw. Let's see if I can get this to play.
And Ms. Caitlin wrote to check on you, so how was blood work? It was excellent.
Excellent. That's awesome.
We did it 3 times on the way getting there. The breathing, we did it at home, we did it in the car, we did it in the waiting room. And after I got blood work, well, so what did we do?
What did we do after?
We went and got breakfast, but then go to the store. We did go look around, we decided not to buy anything. They weren't nice. Well, they weren't ones that you needed for your collection.
A little tangent here, but
Now I'm thinking of that one, right? Well, you might. We'll see. See something that's different. But yeah, it was. I mean, they're terrific there, and it was great because he remembers, of course, 3 years ago. The girl that came out that took It's Like the Manage, like she had done the drawing 3 years ago. So
that was an expert.
and that was and then what they did was, of course, they got everything ready, ahead of time. So they took all, and then we just went in and they had 2 people there, and he was perfect. That's awesome.
okay, so that's a nice feel-good story. And also, I think they hit on like some of the preparatory work and having a consistent figure that was helpful. And that's a positive experience at Children's Hospital. Also, one thing I want to make sure everyone is aware of is there are tremendous resources out there for working with autistic individuals in healthcare settings. On the left is from Aspire. The Aspire group is focused on adults, but a lot of the principles apply, and the resources are phenomenal. Autism Speaks Autism Treatment Network has developed a number of toolkits. There's one on blood draws, actually, that's fabulous. And they're also all free. And then Assert, run locally by Marty Lebetsky and Ryan Kramer, is a fantastic resource. And they actually almost like a hub for finding other resources. They have this resource explorer and a lot of helpful resources there as well. And the last thing I want to comment is there are also resources that you can pass along to your patients to help them prepare for their healthcare visits. This is just one example from Aspire of giving them sort of information on what to do in advance to make it go smoother. I just wanted to end with saying there's a lot more that we're doing. We are heavily recruiting for many studies, as you can see here, kind of across the full age range. Some of them come with a lot of benefits, such as diagnostic testing. Some are in person, some are virtual. And anyway, if you ever are interested in referring patients to us, we would love to see them and connect with them and hopefully become a source of support for them in the future. My email is there, and the website, although the website is undergoing a huge overhaul. But I think I will end there with time for some questions.